Good morning, and welcome to our 14th annual conference of the Midwest Injury Prevention Alliance. This year's theme, Connectedness, Staying True to Our Mission of Safety and Prevention, will highlight topics that inspire, inform, and demonstrate the power of partnerships. The passion behind the program serves individuals and communities, and the impact of policy in shaping the future of injury and violence prevention across our states. I would like to welcome the individuals committed to learning additional information about how we prevent injuries. As practitioners, researchers, learners, we use data to help identify the opportunity. We talk to our communities, and we make sure the proposed intervention is transformative, not only in observation. I am Nicole Burnside, and I'm the Managing Director at the University of Michigan Injury Prevention Center, and I'm also the president of the Midwest Injury Prevention Alliance. And thank you all for joining the first time. The Midwest Injury Prevention Alliance is an organization of injury professionals from the 6 states in the federal HHS Region 5, Illinois, Indiana, Minnesota, Michigan, Ohio, and Wisconsin, that work collaboratively to reduce unintentional and intentional injury-related death and disability. MIPA is similar to the Great Lakes and Mid-Atlantic Regional Network and other networks, formerly known as Regional Network Collaborating Organizations, but its establishment predated the creation of these networks by the CDC. The mission of MIPA is to facilitate development of a coordinated approach for unintentional and intentional injury prevention and control in the region. MIPA promotes the development and sharing of injury prevention planning, evaluation, education, and policy strategies, training, research, and other initiatives among members of the MIPA network. MIPA does this with the goal of reducing unintentional and intentional injuries by fostering collaboration and communication among the MIPA network. This year, we are pleased to welcome over 300 attendees today. Thank you for taking time out of your day to join us, and this is also a record number for our enrollment. Many who are here with us for the first time, again, welcome. I'm also excited to share that we have a new and exciting expo area to explore this year. The expo booths are open and include an interactive poster exhibit featuring important research summaries on various topics. You can view the booths now, but during lunch, we encourage you to visit the booths where you will have the ability to interact with each poster presenter live and learn more about their projects. Now, before we introduce our first keynote panel presenters, I'd like to share thank yous. I would like to thank our conference planning committee, the MIPA committee chairs for suggesting conference speakers and sessions, all of our virtual speakers, including the keynote speaker, panel moderators, panelists, and all the virtual expo poster presenters. Our host this year is the University of Michigan Injury Prevention Center and the Michigan Department of Health and Human Services, the Center of Injury Research and Policy at Nationwide Children's Hospital, and the Minnesota Department of Health. Finally, a few important announcements. We welcome you to take advantage of the networking capabilities of our conferencing platform by visiting with people in the chat on the side of your screen, participate in the polls, and using the networking options during the breaks and during the lunch. You can find these tools in the networking tab along the side of the screen, and you can also chat or use the match tool to be matched with attendees for networking. During lunch, we invite you to grab your own lunch and visit the expo booth to meet our poster presenters, network, or simply take a break and join us back after lunch. If you have questions for the presenters, please use the session chat feature, and they will do their best to allow for time at the end of each session to take questions. Video recordings of each session and any material shared by the presenters will be available on the MIPA website following the conference. If at any time you're experiencing technical difficulty, please message our conference planner, Heather Callier, in the event chat or email mipasummit@gmail.com. Finally, if you are an individual from one of the 6 states in the Federal Region 5 and are not already a member of MIPA, please sign up to become a member to receive and share news about injury and violence activities in our region. You can join any of the following committees: Child Injury Prevention, Communications Membership, Data, NVDRS, Older Adult Falls, or Drug Overdose. By joining MIPA, you can receive our newsletter, invitations, or our webinars, annual meetings, and much, much more. To join, go to MIPA's website, MidwestInjuryPreventionAlliance.org. And now we will introduce our opening keynote presentation. The opening keynote presentation is titled Homeless Mortality and Morbidity Report. This session will present on the second annual statewide homeless mortality and morbidity report developed through a partnership between the University of Illinois Chicago School of Public Health, the Illinois Department of Public Health, and the Office to Prevent and End Homelessness in the Governor's Office. State public health homelessness policy leaders and the university-led researchers will co-present. This presentation will give an overview of the collaboration between state agencies, a high-level overview of the report's methods, key findings from the report, and a discussion of ways cross-agency collaboration has impacted policy efforts across the state. The report is relatively unique in the inclusion of morbidity data drawn from hospital records. The presenter bios are in the tab or in the opening when you open the platform. And our presenters are Amanda Fogelman, Chief of Health Data and Policy, Illinois Department of Public Health; Lee Friedman, Professor, University of Illinois Chicago School of Public Health; Dana Madigan, Assistant Professor, University of Illinois Chicago School of Public Health; Eugenia Olson, Senior Policy Advisor, Illinois Office to Prevent and End Homelessness, and Illinois Department of Public Health. Thank you all for joining us today and look forward to hearing from our session panel.
Good morning, everyone. Give me just 1 second to get fully situated. There we go. Good morning. Thank you for joining us this morning to learn more about the Illinois Homelessness Mortality and Morbidity Report. As Nicole gave a great introduction to us, I will move through these fairly quickly. So our agenda today, I'll give you a little bit of introduction and context. Lee and Dana will talk about the actual report with the methodology key highlights and the year 3 report that we'll start working on soon. And Eugenia will give us some context and the report response. We will have a question and answer session, a brief one at the end. However, during the session, if you would like to ask questions, please do so in the chat. We will be watching the chat and answering those in as much real time as possible. So a brief introduction of us before you get to see everybody live on their camera. We have Lee Friedman, research professor at University of Illinois Chicago, and Dana Madigan, a research assistant professor at University of Illinois Chicago, both at the School of Public Health. Eugenia Olson, senior policy advisor, splitting her time between the Illinois Department of Public Health and the Office to Prevent and End Homelessness, and myself, Amanda Fogelman, chief of the Division of Health Data and Policy in the Office of Policy Planning and Statistics in the Illinois Department of Public Health. So homelessness is a public health issue. It may not seem quite as obvious as other public health issues, but people who are experiencing homelessness are also experiencing health effects of the homelessness, health effects that are public health issues. And those include extreme weather, chronic disease management, and also having access to their substance misuse. Here's a diagram of the tiers of prevention. So at our lowest level here, the primordial, where we're trying to reduce the risk to the overall population by putting policies and mandates in effect to prevent homelessness before it even starts. At the primary, we're addressing at-risk populations with targeted interventions. The secondary, we're going to create infrastructure to disrupt the cycle of homelessness, including providing screening mechanisms. And then finally, at the tertiary, we are providing services to those who are already being impacted by homelessness or at a high risk of experiencing homelessness. So closing the mortality gap between housed and people experiencing homelessness is a key strategy in the Home Illinois Plan, which you'll learn a little bit more about later in the presentation. In order to understand that mortality gap, an academic and state agency partnership was formed between the Illinois Department of Public Health, the University at Illinois Chicago School of Public Health, and the Illinois Office to Prevent and End Homelessness with graphic design. This report supported by the Institute for Healthcare Delivery Design. Our first report, lovingly called the IHMMR, because it is kind of a mouthful to repeat the whole thing out loud all the time, was delivered to the General Assembly in July of 2024. We have an updated report that will be released soon. We are crossing our fingers that that is before the end of the year. So wish us luck for that. That report includes some recommendations, a revamped format. The first report had a morbidity section and a mortality section, and this report has sorted more by health issues, and artwork by people experiencing homelessness in collaboration with Redline Service. We also have continuum of care fact sheets that will be available on the Office to Prevent and End Homelessness website coming soon, and a statewide fact sheet that condenses the report into statewide data in an easy to read and follow format that is available on the IDPH website. Those links to those will be on the slides that you receive on the MIPA website after the presentation. Now I'm going to pass it over to Lee to start his portion.
How you doing, everybody? I just need 1 minute here to share. There we go. And away we go. Okay, so as Amanda said, my name is Lee, and I'm one of the co-researchers on the HMMR report. I'm going to be presenting today the methods and the findings for the mortality data, and then my colleague Dana will be presenting findings on the morbidity analysis. So let's jump into the methods. I want to give everybody a background because we really do believe that our approach is reproducible in other states, particularly in departments of public health that have similar data sources that we have access to in Illinois. So the first issues that we faced was that when we looked at our death certificates and we wanted to do the mortality analysis, is that the National Death Certificate does not have a formal place on their certificate that catches housing status at the time of death. So we had to figure out an alternative approach to identify decedents that were experiencing homelessness at the time of death. So luckily, a team of researchers in the Los Angeles Department of Public Health had kind of laid out the framework for doing this. They did this analysis several years ago, and we took their methodology and we modified it to match the circumstances within Illinois. How we kind of code things and write things down on our death certificates in Illinois, as well as some other additional changes that we made to this approach. But it was really their foundational work that kind of, provided us kind of the road moving forward in terms of doing this. So, in order to identify people experiencing homelessness that on death certificates, we used a four-stage process. So the first stage is we did a text analysis of the death certificates. We had access to all the death certificates within the state of Illinois from 2017 through 2023. And in that text analysis, we searched on homelessness keyword terms, such as like homeless, indigent, and there's a national list developed by HUD, as well as a lot of advocacy organizations have these lists of keywords and recommendations. We took those lists and then we modified it based on how people are actually filling it out and the terms that are being used in Illinois. And you can actually see our full final list on our methods section on the HMMR report. So we're going to do a little, kind of snapshot, but if you really want the detailed methods, we have a very nice detailed explanation of our methodology in our state report. The next step that we did was we looked for people without a home address. And this was a process that was originated out of Los Angeles, and they validated it in Los Angeles, and we validated it internally as well in Illinois. And we're looking for where there's no address, and they use terms such as no fixed abode, no known residence. And that was the second stage for identifying people experiencing homelessness. The third and fourth stages really are kind of part of the same, at least, data set. Is we created this master list of shelters within the state of Illinois, and we use the HUD HIC data, which is kind of a housing inventory data set that HUD publishes every year. We also had lists that were provided to us by the Office of Prevention and Homelessness, as well as lists that were provided to us by local public health agencies, as well as local health advocacy groups and agencies. And we pulled them all together, and then we cleaned it up, and we really wanted to focus on making sure that we had as complete a list as possible, because a lot of facilities will actually have multiple addresses to the same facility, depending whether maybe it's a men's shelter, then a women's shelter, and they might have a domestic violence shelter as well, and they'll all have separate addresses and separate entrances. So we want to make sure that for every shelter, we captured all the addresses for that facility. In addition, for every shelter, often they'll have a shelter name, a project name for that shelter, and then an agency that manages that project. So we also want to make sure we captured all the different names that are related to a specific shelter. And then we matched all the address fields in the death certificates to the shelter address, as well as we did a text analysis looking for these shelter names, the shelter name, the project name, and the agency name, and we matched on those names as well. And as you can see here in these four steps, really the two most effective approaches for identifying the largest bulk of decedents was looking for no known address and matching on the shelter street address. You can see that the homelessness keyword only identified about 10.5%, and this is non-deduplicated. So a person could have been matched on a keyword and no known address. They might have also had a shelter address. But so overall, only 314 out of the total 2,996 decedents that we identified in our 2017 to 2023 year range had these homelessness keywords. So there's actually a push nationally with it by injury researchers and housing researchers to train coroners, medical examiners, funeral directors, and physicians to be more specific in the narratives when they're completing out these death certificates so that public health researchers can better leverage death records for public health research. Because there's plenty of room for improvement, as could be seen here. Now, one of our main concerns was that, this is a new approach. Los Angeles was the first to do it. We're really the second group to use this strategy for identifying people experiencing homelessness within death records. So our concern was, is our ascertainment criteria valid? We've done a lot of different validation tests, but when we looked at the crude mortality rate, comparing, you see the two bottom rows here, the Los Angeles crude mortality rate is 2.95. Ours is 3.93. We're very comparable with Los Angeles that has a very similar ascertainment methodology. But you can see we're still well below Boston and Minnesota. And it's not that necessarily Boston, Minnesota has a higher true mortality among people experiencing homelessness. What they primarily really have is they have access to data sources that allows them to identify individuals that had experienced the homelessness prior to death but might have been housed at the time of death because a lot of people can actually enter medical respite programs, nursing homes, veteran homes, and other types of housing facilities when they have a terminal illness diagnosis or their health deteriorates significantly and can enter housing. So they might have been homeless all the way up to that period, but then at the time of death, they'll appear to be housed. Now, our methodology and the methodology used by Los Angeles would miss those cases. So the next thing that we looked at for our morbidity analysis is we looked at hospital data. And we really wanted to focus on hospital data because, mortality data is great for informing policy, but we wanted to focus on those that are still alive so that we can actually plan out interventions to help people while they're alive rather than when it's too late. So within the hospital outpatient and inpatient data systems, they use the ICD-10 coding system. And within ICD-10 coding system, there is a Z59.0 code that identifies homelessness for that patient at the time of the visit. So we identified all hospital records that had a code for Z59.0. There's another digit that goes after the O, but I'm just for short, I'll call it Z59.0. And so we identified all individuals that had that code. We deduplicated that list. And then because IDPH actually has personal identifiers within their data set, it's not a fully de-identified data set, they're able then to find the full history of medical records between 2017 to 2023 of those individuals that had reported homelessness at some point in time during that period of time. Please ignore the 2022. Our graphic design team, this is something that was waited to be updated. I didn't have it in the time for making this slide, but our second year report will be more accurate in terms of these years. So for this, what I'm talking about today, it really is through 2023. So what we're able actually to do is through this strategy, this two-stage strategy within our hospital records, we're actually able to look at complete hospital utilization within the state of Illinois for people experiencing homelessness. We do not get their clinic data if they go to a free clinic or an FQHC. We wouldn't get that information, but if they come to a hospital, an ED or admitted, we now have the full hospital utilization for this period of time, which my colleague Dana will present. Now, as I mentioned with our mortality analysis, it's not going to be in our year 2 data, but for our year 3 analysis, we know that we're missing people that were housed at the time of death, but had a history of homelessness prior to death. So what we did, again, leveraging the data resources that our Department of Public Health has, is we identified everyone within the hospital system that had a Z59.0 code, and then we matched them to death records. And this ascertainment approach increased our ascertainment of decedents by more than threefold. And so now we have two groups. We have the original group of decedents who were documented to be homeless at the time of death, and the second group of decedents that were documented to be housed at the time of death, but have a history of homelessness documented on their hospital records. And when we compare these two groups, what we actually see is that they're nearly identical on demographic characteristic, contributing causes of death, toxicology findings, and the average age of death. You can see that the average age of death for those that were unhoused at the time of death was 55.5 years versus the second group that we've newly identified of 54.7 years. Okay, so that's the methodology, very high level. Again, if you want more details, we can provide it. It's in our HMMR detail in our HMMR report. So now I'm going to present quickly an overhead view of our mortality results. So when we looked at demographics, really probably the starkest finding is when we compare people that were unhoused at the time of death with the rest of our general population decedents, so those that were housed, we see that those that were unhoused, their average age of death was about 20 years younger than the general population. And this is consistent with research that has been done around the world. When you look at the full world's kind of research on the disparity in average age of death, it ranges between 10 to 20 years. So we're in Illinois on that higher end of that disparity. In addition, when we look at disparities by race and ethnicity, while non-Hispanic white residents comprise the largest proportion of deaths among people experiencing homelessness, when we compare the proportions within people experiencing homelessness with the general population decedents, we see this very large disparity among non-Hispanic Black residents. We see that 40% of our homelessness of our population that were homeless at the time of death were non-Hispanic Black residents compared to only 16.9% in our general population. In addition, we know that veterans experience a high risk of housing instability after discharge from the military. So we have a whole section in our report on veterans as well. And in our mortality analysis, we identified that 10.4% of our decedents who were unhoused at the time of death were documented to be veterans. So another thing that we really wanted to do in our report was leverage every variable within the death certificate as well as the hospital data to make it as expansive as possible. And research shows that people that are experiencing homelessness have a lower social support networks and greater social isolation. So we wanted to look if we could use variables as proxies to get at these measures of social support and social isolation. So within the death certificates, we looked at marital status and the relationship of the key informant to the decedent. So the key informant is a person that whoever's completing out the death certificate knows the decedent well and can provide detailed and accurate information about that decedent. Now, normally, when we look at our general population decedents in Illinois, the primary key informant is a family member. So 94% of death certificates have a family member acting as that key informant. But we see among people experiencing homelessness, substantially lower. Only 65.3% of unhoused decedents had a family member that was the key informant. In addition, when we look at marital status, despite the fact that 22.6% among those that were unhoused had no known marital status because they had no key informant, no information available to the person completing it, we still see a very stark difference in the proportions that were never married. So in the general population, it's a little bit masked here. There we go. It's about 16.4% of the general population decedents are never married were never married compared to 44.7 among those that were unhoused at the time of death. So another thing, again, coming back to validity, our concern always throughout this was our ascertainment criteria valid? Are we really capturing people experiencing homelessness at the time of death? So one measure that we used in our validation assessment was place of death. And if we compare the place of death among people that were unhoused versus people that were housed, we see that 24.7% of those that were experiencing homelessness at the time of death died in an emergency shelter, a hotel, motel, temporary residence, or transitional housing facility. Comparing that to the general population, only 0.1% died in similar types of facilities. And 19.6% of those that were unhoused died outdoors or in an informal setting. That includes vehicles, abandoned buildings, and other types of structures, compared to only 0.6 in the general population decedents. And in this group, in the general population, the vast majority of those dying outdoors or these informal settings died by means of homicide or by suicide. Okay, when we looked at the time trend, what we hear is we have two lines. This top line is the trend for the general population decedents, and the bottom line is the trend for the population that were unhoused at time of death. And this right column are the counts for the general population. The left column is the counts for the population experiencing homelessness. So the top line, you can see generally flat. These three spikes in the middle here are the three spikes during the COVID wave. these two other spikes here are other seasonal outbreaks of viral outbreaks within the Illinois population. You definitely see the COVID spikes. Um, when we're looking at the trend among people experiencing homelessness, up until the very end of 2019, really before about 5 months before the COVID pandemic started, it was more or less a flat trend. There was the monthly fluctuations, but it was a flat trend. Then, towards the very, very end of 2019 through May of 2022, we saw this really precipitous increase in mortality among people experiencing homelessness. It was about a 35.5% increase in mortality during this period of time. And then since May of 2022, we've seen a decline. Now, I don't show data for 2024. We've already completed this part of the analysis for the year 3 report. What we've actually seen in 2024 is that it hovers around this 30 to 40 mark. And we have not had a return to this pre-COVID pandemic baseline mortality rate that we had before COVID started. So it still appears to be elevated. And the reason why I'm not presenting rates is we do not have good denominator data for people experiencing homelessness in the state of Illinois in aggregate. The point in time only captures a small fraction of people experiencing homelessness. So when we looked at contributing cause of death, this is an injury conference. The largest disparities between people experiencing homelessness and our general population really was related to injury. So the proportion dying from drug-related overdoses as well as traumatic injuries, substantially greater proportion among those experiencing homelessness compared to the general population. You can see that 39.3% of those that were unhoused had a contributing cause of a drug-related overdose compared to 5% in the general population. And traumatic injuries were about twofold greater when we're comparing proportions. And I'm going to talk about homicides and colds as well. The one thing I want to just say here, I know this is an injury conference, I'm an injury researcher, is while we have this big disparity on the proportion dying from injury-related causes of death, contributing causes of death between the two groups, still the majority of people that were unhoused at the time of death died from chronic health conditions without any mention or documentation of an injury. And what we see that among people that are experiencing homelessness is because of the stresses of homelessness, a whole variety of environmental, behavioral, as well as medical management issues, we see that chronic health conditions, the onset of chronic health conditions occur much earlier among those with unstable housing and those experiencing homelessness. The progression of disease is more rapid in that population and resulting in an earlier mortality as well. So I just want to call out two causes of injury and death here. So I want to talk about homicide. So we see that the proportion dying from a homicide among those experiencing homelessness was 3.1% versus 1.1% in the general population. And consistent with violence research, we see that among those that were unhoused, disproportionately, they involved younger adults, 44 years and younger, as well as non-Hispanic Black residents. And in addition, only 9.5% of those that were experiencing homelessness at the time of death who were murdered tested positive for drugs associated with substance use disorders. And in fact, of that 9.5%, 3 of them were actually determined to have been murdered by use of those drugs. So a very small proportion were actually intoxicated at the time of their deaths, their murders. In addition, it's cold outside. All of us are experiencing the winter. We don't have our warm state colleagues here. Well, we might, but probably not many. We're concerned about emergency shelters and management of cold-related injuries. So in our death records, we identified 112 cold-related deaths. My colleague Dana's going to show cold-related injuries that were non-fatal. And it's just, when we look at the proportions, substantially higher among people that were unhoused compared to the general population who are housed. And when we look at contributing causes of death that were documented on the death certificates, we see known risk factors for cold-related injuries. Those that died from cold-related injury disproportionately tested positive for alcohol. They disproportionately had nutritional deficiencies and heart disease. All can increase the risk for cold-related injury by affecting the body's ability to thermoregulate itself. And from a social risk factor, we also see that a greater proportion of those that died from a cold-related injury, just among those that were unhoused, were not born in the Midwest. If we look just at Illinois, 22.3% of those that died from a cold-related injury who were unhoused were born in Illinois, compared to around 55% in our overall population of unhoused decedents. These cold-related deaths occurred at a median minimum wind chill temperature of 19 degrees Fahrenheit. But very importantly, over 10% of the deaths occurred when the minimum daily wind chill temperatures were above 32 degrees. And this is very important from a policy perspective because local shelters, cities, and agencies often don't have expanded shelter hours if the temperature doesn't fall below 32 degrees, and that's the non-wind chill temperature. And even some have much lower levels and thresholds for having expanded hours. So we definitely, the risk is observed well above 32 degrees in our population. Okay, so that's it for me. I'm going to stop sharing. I'm going to hand it off to my colleague Dana, who will present the morbidity analysis.
Sorry, I clicked unmute and it didn't want to cooperate with me, but we're going to transition to the morbidity results, and we're actually kind of really proud to be including the morbidity data in this report because, as you are probably feeling after listening to Lee's finding, the mortality data is really heavy, and we're always looking for upstream intervention points. And so here, maybe we could start doing interventions and policies to kind of get higher on that pyramid for levels of prevention that Amanda showed. So we found from 2017 to 2023 nearly 2 million visits for people identified as experiencing homelessness at some point in that time period. As you can see, the majority of visits were for the emergency department, and only a fraction of those were coded with the Z59 code. So this is where, our partnership with IDPH and their additional data capabilities are really, really helpful in that they can kind of find all of these other visits because we know that homelessness is really undercoded throughout the healthcare system. And then using the information that IDPH has, we don't get the personal identifiers, but we're able to kind of drill these nearly 2 million visits down to about 75,000 unique persons. And there's a median of 14 hospital visits per person. And this is over the 7 years. This is not per year. Nearly everybody in the hospital data set visited an Illinois hospital more than once, and about a quarter had almost 30 or more visits over the 7-year period, which really accounted for about 2/3 of the hospital visits. And we see that these high utilizers of medical care in the hospital setting are really disproportionately diagnosed with serious chronic cardiovascular, respiratory, neurologic, and renal disorders. And so we hear a lot of messaging that this is limited to people with psychiatric and substance use disorders. And we just want to highlight that while that certainly is a concern for this population and in the housed population, that it's not limited to that. And really, our unhoused neighbors are experiencing a lot of serious health conditions that require this care. And then what we see is the demographics and health issues in when we look at the hospital cases, overall. And then by unique individuals really matches what we're seeing in the decedents. And so we think we're capturing a similar population using these different methodologies. And while that's still probably an undercount, we feel that these methods are fairly robust and, like Lee said, could be replicated in different jurisdictions. And then this is, I think, something that is also really striking that we found is, so when we look at those 7 years, these dark blue lines are the years that someone has a Z code for experiencing homelessness, and the light blue line is when they throughout that year don't have a Z code for any of their visits. And what we see is when they have these Z codes, we're seeing much more frequent hospital admissions and emergency department visits by this population. And I think it just really highlights that link between housing and health. So when we look at it by visit, about 2/3 of the visits were for males, and they also had a higher proportion of the visits with the Z59 code, nearly 3/4. Visits are predominantly for adults aged 25 to 64, but we do see over 25,000 visits for children under 18. A much higher 7% or 8% of our visits were for youth, which for the homeless services and that area is defined as being aged 18 to 24. And then we have about the same amount, 7% for people that are age 65 and over. Most of our visits are for Illinois residents, and less than 10% of the visits had no insurance coverage noted. And similarly to what Lee presented, we're seeing this disproportionate burden among our Black African American population. And so while the majority of visits were for non-Hispanic whites and Black African Americans, fairly similarly, even though these proportions vary a little bit by visit type, if it was ED versus admissions and coding status, this is really disproportionate to what you would expect to see based on our population demographics. The majority of our visits are, probably not surprisingly, in the greater Chicagoland region and occur in urban counties throughout Illinois. But I really want to highlight that visits by people experiencing homelessness were identified in every region throughout our state, no matter how you kind of look at that, whether it's by EMS region, IDPH region, counties, urban, rural. And then even when we start stratifying down by visit type and coding status, or looking at subgroups of like young children, teens, youth, and pregnant persons, they are represented throughout the state consistently. We do not see the same sort of peaks that Lee saw temporally, but we do see admissions kind of peak in August and emergency department visits in the cold weather months, November to January. We really did not see that COVID trend that he had described. Our primary diagnoses and comorbidities for all of the visits collectively for admissions is mental disorders, and emergency department is kind of coded as symptoms or nonspecific. We often see substance use disorders, musculoskeletal connective tissue disorders, disorders of the respiratory system and circulatory system, and then for comorbidities related to drug use, hypertension, alcohol use, psychoses, chronic pulmonary disease, and depression. And then here, this is just kind of showing that in our admissions, which, could represent, more serious hospitalizations, but also kind of allow the opportunity for more thorough history gathering and coding. We're seeing a high number of comorbidities in this population, with over 60% of those admitted having 3 or more comorbidities. And then, like Lee said, this is an injury conference. So approximately 15% of our visits were for injuries. These are most commonly poisoning, falls, assaults, or homicide, temperature-related injuries, and transportation-related injuries. With that, predominantly it's pedestrians or bicyclists struck by motor vehicles. We had nearly 40,000 visits from assaults. These are more commonly treated in the emergency department, and nearly 20,000 visits from suicide attempts, and these are more commonly resulting in admissions for a variety of reasons. Substance use disorders consistently appear as a top primary diagnosis, comorbidity, and cause of injury in our overall analysis. And over half the visits note that the patient had a substance use disorder, but only about 10% are coded for intoxication at the time of hospital visit. And the most common agents cited are nicotine, alcohol, stimulants, and opioids. And I underlined the ones that are related to intoxication versus just overall substance use disorder. So you can kind of align that if you are looking at the slides later. And this is far less common in visits for children, youth, and pregnant persons. So, we see this disparity again between identifying a substance use disorder and being intoxicated at the time of visit. So, about a quarter of pregnant persons had a substance use disorder, but only 1% of the visits for pregnant persons noted intoxication at the visit. And then for youth and children, we kind of see variations with that, but also kind of that similar reduction from the coding for intoxication. And so these hospital visits represent over $22 billion in billed charges. Now, this is not what is reimbursed or actually gets paid out. And then the median bill per visit, regardless of the Z59 code, is approximately $20,000 for an admission and nearly $3,000 for an emergency department visit. And for admissions, our median length of stay was 5 days, which is a pretty substantial hospitalization, and over 3% required mechanical ventilation. And we use these as proxies for severity. And then I think what's really striking here is the majority of discharges across these visit categories were routine, and that is generally to home or self-care. And this is actually slightly higher in visits coded for homelessness with that Z59 code, and higher in emergency department visits. And this presents a variety of challenges, and it's a barrier for continued care or treatment. The amenities to support the health and discharge instructions, aren't available if you're being discharged to the street or potentially shelters and things like that. And then there's also really big concerns because, sometimes these health conditions and discharge conditions can exclude you from being able to enter a shelter or other types of services. And so that's where I'm going to stop. And I went through it super quickly because I definitely want to give enough time to my colleague, because I think what's been really exciting for me with this work is seeing how it's helping support policy and interventions, and hopefully really making a difference in the lives of folks that are affected by homelessness. So, Eugenia, I'll turn it over to you.
Thank you. Thank you so much, Dana. Before I get started, thank you so much, everyone, for joining. I'd like for us to just take a brief moment of silence to honor those represented within our report who have died and have experienced homelessness within their lifetime. Thank you. So my name is Eugenia, and I will talk a little bit more about the state's homelessness context, as well as, how we're responding to the report, and also why the report was necessary, as was mentioned previously by my colleague Amanda. In 2021, the Illinois governor signed an executive order to fight homelessness in Illinois by creating an Illinois Interagency Task Force, a Community Advisory Council, and the Chief Homelessness Officer, and the Illinois Office to Prevent and End Homelessness. In 2022, the Home Illinois Plan, which is the state plan to prevent and end homelessness, was released in and shared in 2022. So in July, though, the Home Illinois bill kind of codified the Office to Prevent and End Homelessness and really showed an investment to address homelessness in the state of Illinois. Our vision really is that if you live in the state of Illinois, and you are in need of support, like no one should live on the street or in the shelter or in overcrowded housing, and that they earn enough money that they can afford housing where they want to live, without the fear of losing their housing or being evicted. And then, though, if a housing crisis were to occur, that there will be significant safety nets in place to allow for resolution of those issues and to stabilize their housing. Um, we do this by, coordinating the state of Illinois strategies around homelessness by partnering with community members, investments, financial and otherwise, to help build that strong safety net that I referenced in the previous slide, and to really build more affordable housing and permanent housing for individuals within Illinois facing homelessness or housing insecurity. Part of that is to embed advisors or policymakers or policy thought leaders in state departments. So you'll see there are individuals located within the Department of Human Services, Illinois Housing Development Authority, the Illinois Department of Corrections, Illinois Department of Public Health, which is myself, the Illinois Department of Healthcare and Family Services, as well as DHS, really thinking about how these different entities or departments can come together to address homelessness in the state of Illinois. I want to briefly mention the continuum of care, as this is a significant staple in Illinois and other states that really receive federal dollars that impacts homelessness or impacts housing within the state. There are about 19 COCs within the state of Illinois that really serve as the planning body that coordinates housing and services, and provides funding to agencies to support people that are experiencing homelessness or are newly housed. They're also responsible for the homelessness management information system, which is a system that captures information or data related to individuals that may kind of come in and out of housing or in and out of shelter services. Anyone that kind of touches the shelter system or other systems designed to support people experiencing homelessness go through the HMIS system. So some of the core responsibilities or roles of the Office to Prevent and End Homelessness, which I'll refer to as OPA moving forward just because it's so long, really is to drive state investments. And we do that by scaling solutions to end homelessness, right? So any investment financially that supports individuals that may be experiencing homelessness from a macro level, that's part of the role of OPA. Also to build kind of state agency community capacity, identify some policy solutions to address homelessness, create program innovations, which could include pilot programs that are trying new ideas or new things to address homelessness in the state of Illinois, advancing research and data capacity, which is one of the examples you're seeing here with the report, and engaging other community and government elected officials to impact homelessness across our state. So the interagency task force that I mentioned earlier really comprises all the different departments that you see on this page, and public health right there is a utilizes their expertise to really see how people that are experiencing homelessness, how are they being impacted, how their health outcomes being impacted, how their social determinants of health being impacted by experiencing homelessness, and working to really address those needs. So there are departments like state police, corrections, juvenile justice, board of education, economic security, aging, and the rest that you see here. Some of the other frequent partners, Department of Human Rights, Department of Transportation, Secretary of State, Governor's Office, and others really work together to, one, decrease silos amongst departments, but also to collectively address homelessness within our state. And so from the the interagency task force comes like this state plan, right? And so the one that's currently out 2024 to 2026. And there are more than 125 specific state programs, policies, or process commitments related to homelessness from the 16 Illinois agencies. The plan is really designed to incorporate data on homelessness, incorporate how programs are being funded, how programs are being utilized within the population, and how departments can work together again to address homelessness in Illinois. Some of the key pillars within the Office to Preventing Homelessness, or OPA, is really to increase affordable housing and supportive housing, build more affordable housing, bolster our safety net programs, including shelter and other services for people experiencing homelessness, secure financial stability for low-income Illinois families, and close the mortality gap, which is one reason why we're here today. To better understand the mortality gap, as my colleague Amanda mentioned earlier, the Illinois Homelessness Mortality Morbidity Report was developed. So we acknowledge that early access to healthcare and psychiatric services and housing has been shown to reduce morbidity and mortality, as my colleague Dana mentioned at the end of her presentation, but also improve surveillance data of the issues and who is experiencing homelessness is necessary to move the work forward. We realize that the data that we currently have and the data that currently exists among homeless populations is a significant or severe undercount, and we're working on solutions to improve the data that we have. And one of the things I think that's important to note within the report, as Lee mentioned, there are specific data points and specific information for these specific groups within the homeless population. So these are like subpopulations amongst the group to really understand how homelessness is impacting specific individuals or specific populations within our state. So some of the goals that these aspirational goals that have been thought about to enhance the annual report is linking the hospital records data and death data, which is actually what Lee talked about earlier today. Also collaborate with the COCs that I mentioned to kind of think about how information can be shared. Assess how impact on new policy related to ordinances or banning encampments and items like that that impact or criminalize homelessness, how that impacts the mortality and morbidity of those individuals, and then also to possibly develop an online dashboard for easy use and like customizable reports. So when we think about recommendations, one of the things I think is important to mention is that we don't want to just have a report that sits on the shelf. We want a report that has some action behind it, some thoughtfulness behind it, and how communities, organizations, departments, policyholders, policy builders can work together really to address homelessness. And, as Lee mentioned, Dana mentioned, there's just a lot of data that's missing, an undercount that's missing, a significant amount of hospitals that providers that may not identify individuals that are experiencing homelessness as they enter into their hospital settings, whether it's through an emergency department or a overnight stay. So one thing that we wanted to do is to really work to enhance the identification and documentation of individuals that are experiencing homelessness, that enter into our healthcare systems and settings to really understand what their needs are and how to address them. We also like to think that we could think about how we can integrate larger data sets into our understanding of homelessness. And also, what's the service utilization? How often are individuals experiencing homelessness may access Medicaid or may access food stamps or may access any program designed to, within that safety net that we discussed earlier, to enhance their ability to decrease negative health outcomes. We also wanted to take a look, though, at the feasibility of the Mortality Review Board for individuals experiencing homelessness as a way to dig a little bit deeper. I know Lee talked a little bit about the medical record, and how impactful and important it is to really get an idea or a snapshot of a person's integration or engagement with the healthcare system. Like, what some of those medical conditions, or when did they start, how long did they start, and why did that person pass away, either while experiencing homelessness or being newly housed. There's also interest in conducting a statewide warming center assessment, really to, as Lee and Dana mentioned about individuals who had significant injury and or death with the contributing cause due to extreme weather. I think Lee mentioned it was 112 individuals over that time frame, 2017 to 2023. And some may say, well, 112 is not that many, but to us, one is too many. One is too many. Individuals that live unsheltered should have access to warming spaces in the dead of winter, especially in communities like Illinois. And so we really want to understand more about like how systems are operating. How is it communicated to organizations or people experiencing homelessness that may live in a tent nearby or far away from a warming center. What the transportation system is like, how people can actually access those services. So again, that's something that we are starting to look at as well. We're really also interested in exploring opportunities to gather housing status at death. That will really help us understand why, when, how more individuals are passing away due to experiencing homelessness, but also it gives us an idea in a semi-real time fashion to understand more immediately the outcomes. And then lastly, I'll add here that we'd like to develop and implement a provider engagement strategy, really to engage providers and healthcare system staff, whether it's social workers, community health workers, nurses, providers, that really lean into understanding what the needs are for people experiencing homelessness, what some potential discharge strategies, and how we can support people that enter our systems, address maybe some of our implicit biases around homelessness, and really address the needs of those individuals that enter our system. And so some of the state strategies in response to the plan was the increase of medical respite, increasing a health-focused permanent supportive housing program, increasing access to resources through the Medicaid 1115 waiver, and then the substance use disorder focused street outreach programs. So I'll just spend a brief amount of time here talking through this, and I don't know if there are any questions that may come through later. Feel free to add them now too. So with medical respite, I'll dive a little bit deeper into medical respite because I think it's such a unique and important strategy to address health outcomes and conditions for people that are experiencing homelessness. And so for those who don't know what or never heard of medical respite, imagine going to a doctor's office for surgery, and you have your surgery and they say, hey, go home, rest for about 2 weeks, then come back and see me. Or you're prepping for colonoscopy, and anyone who has prepped for a colonoscopy know how challenging it is and the need to be near a restroom and a shower. So the medical respite program really creates a safe space or a space where individuals that are experiencing homelessness, that are not sick enough to stay in the hospital, but not well enough to go back to the street or to a shelter, they can come into this place where there's support, medical support, there's healthcare system navigation support, and there's actual rest and healing. Away from the elements to actually rest to support their healing process. And so the Office of Preventing and Homelessness, in partnership with the Illinois Public Health Institute, has launched more medical respite programs throughout the state. If you see here on this slide, from 2022 to 2025, there's been a significant increase in medical respite programming and support, up to 70 plus beds for people experiencing homelessness that need to have those intense or increased medical support and assistance. Also, too, just wanted to give you a quick snapshot of some of the medical respite programs throughout our state and where they are located, but also to there is always interest in growing this. So they just actually closed an application process where they are looking for individuals to begin to think about track one, like what can medical respite look like within your community. There's also there was launched health-focused permanent supportive housing to support individuals who were facing the need for recovery due to opioid use disorder. There was a $20 million investment in permanent supportive housing to support those individuals. And then again, this is based off of the findings from the initial report. And then lastly, there was a program designed to support individuals that were experiencing homelessness that lived on the street that may also have substance use disorder that needed additional support in that way as well. So ultimately, these findings have been paramount to allowing the state to think about what processes, what programs, what funding, or what investment could help drive and support the efforts designed to support people experiencing homelessness. We've been on the road really socializing this information, socializing the report, and really sharing out the negative, impactful outcomes that impact people that are experiencing homelessness, really trying to learn ways that we can address it. So if you, after this conference and you're thinking about this and you have ideas, definitely feel free to reach out to us as we begin to think about how over the next few years we can address homelessness collectively as a state. And then just to bring home what Dana mentioned earlier, how housing is a significant solution to addressing homelessness. Housing keeps people safe. Housing creates opportunities to decrease stress related to what I'm going to eat for that day. Where am I going to sleep? Where can I store my medication? How can I prepare nutritious meals? Housing, housing, housing. And we notice that when people are housed, they're less likely to use the hospital and they're less likely to stay there for more than one day. So we are leaning more into like some housing solutions, but also other solutions that impact people experiencing homelessness. So with that, I'm going to see if there are any questions that need to be answered. Thank you so much for your time today.
Thank you. And want to thank Amanda, Lee, Dana, and Eugenia for their presentation, and want to invite you all back to the screen to see if we have any questions. I saw there was one raised hand, and if you could add your question to the chat, Ashley, I can read that for you. And there was one question that came in the chat during the session, Dana, and you responded, but would you mind just reading? Is the high insured rate expected, or maybe I misunderstand what you presented? How do you think about the differences between the morbidity and mortality? And maybe if you could just answer that here for the group.
Sure. So some of our previous work before we started, this report covered the period of the implementation of the Affordable Care Act. And so we saw a substantial increase in the number of folks who had insurance coverage, following the implementation of that. So I think this is pretty much in line with what we've seen, and we have a high number of people identified as Illinois residents. So they're, I think, being better connected to different health insurance programs and coverage that's been introduced since the Affordable Care Act. So that's, I think, in alignment, and may seem high, but I think it might be our new normal as long as these policies and services stay intact. And then related to the differences in what we see in the mortality and morbidity data around COVID, I don't know that I can say this, for certain, but it's my belief that there are a lot of policy and service changes that were made in response to COVID, moving people out of congregate shelters, providing different services for both the housed and unhoused population. We saw significant disruptions across the board. But I really think that we're not seeing these huge spikes in hospitalizations as a result of the success of those programs and policies, and the ability for people to kind of be able to isolate and manage milder cases on their own and follow that guidance without needing to access the hospital. So maybe if we had earlier, like testing data or health, um, like health clinics or earlier points of contact in the healthcare system, maybe we would see kind of spikes that are also reflecting that. But I think it was the success of the policies to kind of keep our hospitals open for the severe cases and support folks as they're challenging, navigating all of the challenges with the COVID disruptions.
Thank you, Dana. I have another question from Melissa. It says, this is amazing work and important work, or maybe it's a comment. Thank you for highlighting the impact of homeless or health and lifespan, etc. This is also important as we think of some of the anticipated changes over time with ACA. Has this information been shared with elected officials making future health care costs work, or with media? Seems super important to keep expanding coverage for folks, not limiting coverage and access.
I can address that very briefly. I will say that our chief homelessness officer at the state, which is Chief Christine Haley, has done a significant amount of work talking with the governor's office and elected officials around the impacts of homelessness and the negative health outcomes associated with them, as well as the need for increased funding and investment in housing and supportive services for people experiencing homelessness. So yes, as a matter of fact, also in the media, she was just in the media a couple of times last week and beyond, just really driving home the point about how important it is to support our neighbors that are experiencing homelessness. So thank you so much for your question.
Thank you. Thank you all so much for joining us this morning and being here. Please feel free to reach out to our presenters in the chat, and we would love to give you a little minute to stretch your legs so we can get to our next session. We have 1 minute and one more comment here, but this is also an indicator of the value of our insurance programs. Oh, Linda was tacking on a comment from her original post. Thank you, Linda. That is so true. All right, we'll see you all back in a moment. Thank you so much. We'll give you a virtual round of applause. We appreciate you and all your hard work. And we will see you all back in a couple of minutes. Thank you.
Thank you.